طيب نحن ممكن نبدأ. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody for this new session of the Cornea Club in Sinjab Academy. And we are very proud and we are very honored to have Professor Dr. Tarek Katamish from Egypt with us tonight. And he is a very well-known and renowned figure in the cornea world, especially in the lamellar keratoplasty and DMEC. Professor Tarek Katamish is a professor of ophthalmology in Cairo University, and he has plenty of participations in many of societies and international conferences. And he conducts wet labs on this subspecialty in the conferences and his own center in Cairo as well. Tonight as well, I'm very delighted to have Dr. Barak Qubaisi from Syria. He is a cornea and ocular immunologist, specialized from Massachusetts in the USA. And he will be with us as a moderator, co-moderator with me, to make the session more powerful. So thank you very much, both of you, and Professor Tarek, the stage is yours.
Bismillah ar-Rahman ar-Rahim. I am very honored to be today with Dr. Mazen Sinjab and as well as Dr. Barak Qubaisi. It is an honor to be part from the Sinjab Academy and to share my expertise through this prestigious platform. I will speak today about anterior lamellar keratoplasty. So I think I have to share my screen now with Professor Mazen.
Yes, please.
Okay. Full thickness corneal replacement is not accepted anymore except in very limited indications. Lamellar keratoplasty is a form of selective tissue transplantation in which only the diseased part of the cornea is replaced and the unaffected healthy cornea is retained. As you know, the corneal anatomy, the cornea is arranged into layers. The epithelium, Bowman's stroma, it is called the anterior lamella, and descemet and enthelium, the posterior lamella. So if we have a pathology in the anterior lamella of the cornea, doesn't make sense that we change the whole cornea. We just change the diseased anterior lamella by an operation called anterior lamellar keratoplasty. On the other hand, if we have a pathology in the posterior lamella in the endothelium, there is no sense to change the whole cornea. We just change only the diseased endothelium by an operation called endothelial keratoplasty. So DALK means deep anterior lamellar keratoplasty. The indications for DALK is any corneal pathology with normally functioning endothelium. The most common causes for these indications are keratoconus and post-LASIK ectasia, superficial and stromal opacities and dystrophies. What are the advantages of DALK over penetrating keratoplasty? First of all, there is no endothelial graft rejection. Second, there is no graft failure since we are using the patient's own healthy endothelium. It is an extraocular procedure, and the short-term use of topical steroids since there is no endothelial rejection, the stronger growths, and another advantage of DALK is that it expands the pool of potential cornea donors. We can utilize lower quality donor corneas, and you can use one donor cornea for 2 transplants using the stroma for DALK and the endothelium for the MEC. And the learning curve usually goes without complications. This is the concept of corneal splitting. We split the cornea into 2 grafts, the stroma and the epithelium for DALK, and the endothelium and descemet membrane for the MEC. You can use this graft the same day, or you can even transfer it to another hospital or another day. This is what I mean by the smooth learning curve, because whenever you have complications and you have to convert to penetrating keratoplasty, you will do the operation as PKB. So what are the disadvantages of DALK? Of course, it's technically difficult, somehow longer in surgery time. The learning curve is somehow tough. The optical quality is more or less the same as penetrating keratoplasty. The DALK operation has always known to have a tough learning curve. However, in the next 45 minutes, I hope that I can share with you lots of tips and tricks, which in my opinion will help you achieving the perfect big bubble DALK. We have three ways to do DALK, either by hydrodissection or viscodissection or air dissection, what we call it the big bubble DALK. I will concentrate in my talk today on the tips and tricks of the big bubble DALK. These are the steps of big bubble DALK. We make first centration, and then we do partial thickness terrifination using the Hasberg terrifine. And then we do the big bubble formation by injecting air in the stroma. And then we do debulking of the stroma. And then we open the roof of the big bubble by the brave slash. And then we cut the remaining stromal flaps. And then we do donor stripping, preparing the graft. And finally, we do suturing. As you know, the most important step in all these is the big bubble formation, which is a key step in operation. The secret of success is injecting air deep in the stroma. When you inject the air in the stroma, the bubbles will form until gradually the pressure will build up until we make a descending membrane detachment, what is called the big bubble. I will go through the steps of the operation, but there is groups of tips, mainly 4 groups of tips. The first group is how to get the big bubble consistently. This is very important to have a high rate of success. The second group of tips is how to differentiate between type 1 and type 2 big bubbles. So we have to be aware of the different types of big bubbles. The third tip, you have to diagnose some tricky situations. I will mention it in the proper time during my lecture. And the fourth group of tips, you have to open safely the big bubble roof. So I will go through the operation step by step, and I will mention tips along the way. The first step is marking the cornea center. You have to spend few minutes for proper centration, because in keratoconus, the pupil is displaced by the cone of the cornea. So you have to spend some few minutes for proper centration. Use a caliper. This is my way. I'm using a caliper on fixed distance and making a mark from the temporal, nasal, superior, and inferior limbus. And inside this square, this is the corneal center, as you see, with proper centration. Be careful. If you don't spend these few minutes for centration, you may end with this ugly, eccentric terrifination. The second step, you have to make what I call terrifine adjustment. You have to know your terrifine. This is a terrifine, our terrifine. This is the handle for holding the terrifine. This is a spoke for turning the blade. And this is the vacuum for the vacuum chamber. And this is the ultra sharp blade. And this is a continuous vacuum chamber. So you have to make terrifination at certain depths, not to penetrate the anterior chamber. You have to adjust the blade, your blade, at what we call the 0 mark. This 0 mark when the blade is aligned with the vacuum chamber. And you have to know that moving the blade quarter turn, it will cut about 60 micron of the cornea. So if we have this schematic drawing of the terrifying blade, this is the outer tube, this is the inner tube or the vacuum chamber, and this is the terrifying blade. So when you have the terrifying blade aligned with the vacuum chamber, we call it 0 level. And when you withdraw it anti-clockwise, it goes up away from the cornea, and when you withdraw it clockwise, it goes down to the cornea to cut the cornea. So as I have mentioned, you have to spend a few minutes for terrifying adjustment. This is how we adjust terrifying. We have to align the blade with the vacuum chamber. This will be called the 0 point, and the terrifying will start cutting from this point. The third step is doing partial thickness terrification. How many quarter turns am supposed to do? Is it a standard depth of terrification in every case of corneal opacity or keratoconus, or it is variable from case to case? Yes, it is variable from case to case, and this depends upon the corneal thickness at site of terrification. So this is my way of calculating the amount of depth I have reached in each case. If we imagine this is the cornea, and this is site of terrification, example 8 millimeter. So we will take pachymetry at this site, and then we take the thinnest pachymetry as a safety margin, and then we make another safety margin of taking 80% of this thinnest pachymetry, and then we divide this 80% by 60 micron. This will give me the number of terrifying tears I have to do in each case. I stress again, what is important for me is thickness at site of terrification and not the thickness in the center. So this is the pentacam map. We come, for example, at this 8 millimeter diameter, and we look at this point through the color code, and we choose the thinnest location, and we start doing our calculation. For example, if we have the thinnest pachymetry is 540, we take 80% of this 540, this will be 430. We divide 430 by 60, will give me about 7 to 7 quarter turns. This is very important to have deep terrification. This calculation is applicable to the terrifiers used in my country, whether the Katina or the JEDMED, but it's not applicable for other terrifiers which needs another way of calculation. So you have to know your terrifying, you have to know how you adjust it, and you have to know how you do deep terrification. After calculation, you go on the patient's eye and you do your terrification, and then you see, you will look to the depth. It looks very deep terrification, and this is the very important step in achieving the big bubble. So not only the femto laser can reach this deep level, but a simple manual technique can do so. Go up to 80% of the corneal thickness at site of terrification. We come now to the key step of the operation, which is the big bubble formation, which is, as I have mentioned, a key step, and we'll stay for some time describing this step. If you are using the needle to inject air, if we put our needle in the stroma very superficial because we are afraid to puncture the cornea, this will be safe, but the chances of success will be low because I'm injecting very superficial away from target. But if I place my needle very deep in the cornea, it is dangerous. I may perforate this membrane, but success rate is high because I'm injecting very near this membrane. So the solution of this is we have to use a blunt cannula, not a needle anymore, and we have to do it and to place the cannula very deep. So the secret of success is using blunt cannula and placing this cannula as deep as you can in the stroma to have a high percentage of big bubble formation. I am using, there is a well-known 3 cannulas in the market. Of course, I have no financial interest. Donald Tan cannula, Sarnicolas cannula, and Foglas cannulas. All cannulas have 27 gauge, blunt tip, and the pore is down. But for myself, I'm using a Donald Tan cannula, but all of these cannulas are quite good. So we have done a very deep groove, but we need to place the injecting cannula deep as well. it doesn't make sense that we did a deep groove and then to inject superficially. So I will show you now my own way of how to make a deep injection. First of all, we define the deepest part of the groove by making minimal dissection by crescent knife, as you see, just defining the deepest part of the groove, then making a small nick by a sharp insulin needle, just a ½ millimeter, and then I introduced a blunt spatula 27 gauge in the deepest stroma to make a tunnel very close distal membrane, and then after that I go with my blunt cannula and 5 cc syringe very deep and injecting with some force. You will get the big bubble immediately, as you see if you follow these small tips. Again, define the deepest part of the groove by just minimal dissection. Make the first part of the tunnel by just a nick by insulin needle, and then make the tunnel very deep by spatula. And after making the tunnel very deep by spatula, you can go by your cannula very deep as well, very near distal membrane, and you stop and inject with some force. You will be having the big bubble, as you see immediately from the first injection. As you see, it is always a reproducible technique. To summarize again how to get the big bubble consistently, look carefully at the pentacam map and choose the thinnest corneal thickness at site of terrification. You have to know how to adjust the terrifying at 0 mark. You should make a very deep terrification. You should inject air very deep as well. You have to use blunt cannula and not the needle anymore. If you follow these tips and in a straightforward keratoconus case, you will be having a very high success rate. As you see, it is always a reproducible techniques if you follow these small tips. Moreover, the aim changes not only getting the big bubble from first injection, but immediate bubble formation without even stromal emphysema. To prove my theory of the importance of injecting very deep, when you are very deep, we are accustomed in any big bubble, we have to have some emphysema, some whitening, and then the bubble forms. But if you are injecting very deep, as in these examples, you will find the bubble will form immediately without any even emphysema, because you are injecting very, very close to your target. Watch carefully these 4 videos. When you inject, the bubble forms immediately. You see, there is no even stromal emphysema. This supports my theory of the importance of injecting very deep. Another example, you see, it forms immediately without any emphysema. Of course, it's not our aim to have what we call transparent bubble, but our aim to inject very deep to have a high success rate, as you see. There is no emphysema. The bubble forms immediately because I'm injecting very deep. A good sign and tip, as we know, the anterior stroma is tough, but the posterior stroma is not as tough as the anterior stroma. So if you are introducing your spatula and you find sudden release of resistance, this means that you are very deep in the stroma, as in these 2 examples. Look carefully here. You look carefully, some resistance, and then this jump of the cannula in front of you means that you are in the proper deep space, and you will be having the bubble. Another example, you see this giving away of the spatula means that you are very deep and you inject with a high success rate, as you will see now. What are the signs of big bubble formation? We have 3 important signs to diagnose that you have got the bubble formation, because at the beginning you may be confused between stromal emphysema or big bubble formation, so that these 3 signs are circular, well-defined edge. This is very important. There is no bubble without a circular, well-defined edge. But on the other hand, intrastromal air is white with feathery edges. The tension should rise. You have the globe will be firm or hard, and there is a very important test, what is called the small bubble test. So this is what I mean by the well-defined edges characterized by the big bubble formation. This is a principle of small bubble test. If you have the big bubble in the middle of the anterior chamber, and then if you inject a small bubble in the anterior chamber, there is no place for this small bubble to occupy the center. So it will be displaced in the periphery in what we call it a kidney-shaped configuration. This means that the big bubble is formed. But if you find this small bubble in the center, this means that you don't have a big bubble. So this is a small bubble test. Injecting air, you will find the bubble is trapped in the periphery of the anterior chamber in a kidney-shaped configuration because the center of the anterior chamber is occupied by the big bubble. Another example, you see these small bubbles in the periphery of the anterior chamber. We call it a positive small bubble test. Another example, as you see here, you inject the air and inject again, you will find that the bubble is trapped here. As you see, the bubble is trapped here. So this is a big bubble formation, and this is positive small bubble test. A very important tip also, sometimes when you inject, you find some resistance for enlarge the bubble. Our aim is the bubble is to have to cross the edge of a terrifying edge. You see, we are aiming that the bubble edge crossing this edge. So if you are injecting and you're having some resistance, you see, there is some resistance of enlarging bubble here. So keep on injecting until suddenly you will find the bubble will bob out and traverse the terrifying edge. Another important tip also, that if you have some resistance, you may do a very good tip. You have some resistance, as you see, the bubble doesn't want to enlarge enough. So you can stop, make paracentesis to lower the aqueous pressure, and then go again in the same track and inject. You will find that the bubble will expand to the proper size across the terrifying edge. Sometimes we have the big bubble from the first injection, as I have shown previously, but sometimes you may need to inject second time or third time or even up to 5-6 times. So this is examples of how to get the big bubble from the first injection. Usually the straightforward keratoconus patients has a high success rate, and if you are making the deep injection, you will be having the bubble from first time. If you are using needle, as this example, you see this is the first injection. This is what is called stromal emphysema. You see these feathery edges. This and second injection, you will find bubble will form. See, so this is the formation of the bubble. Second injection. Sometimes you may need repeated injection. This is the first injection. You have no more than stromal emphysema. This is no emphysema, and you go again the same side, injecting again, more emphysema, tension is still soft. You see, tension is still soft. You make a third site, which is deeper, injecting another time, but again you have more emphysema. You make lamellar dissection and inject for the fourth time. Watch carefully this time. When you inject now, the bubble will form. Look, the bubble have formed now, as you see, and I have continued the case as DALK. So you have to be patient and determined, and don't lose hope of obtaining the bubble. But what if big bubble is impossible, either due to intraoperative complications or as a preoperative decision in some special cases like keratoconus with previous hydrops, trauma with deep scar? What would be the solution? The solution is manual dissection or layer by layer dissection. This is my own technique of doing lamellar dissection or manual dissection layer by layer. If we fail to have the bubble, you see, we go in the periphery of the cornea by spreading action of the scissors blade, and we go in a spiral way, and every turn you will find yourself in a deeper plane. And when you are in a deeper plane, you will find the stroma is not adherent, and you can peel it off. So you can do this repeatedly, and until you will find the section is very easy. As you see the section is very easy now, and you see the peeling peeling of the stroma. This peeling couldn't be done except in the very deep stroma. So by doing this with some patients, you can continue the case as DALK, but without big bubble. So sometimes we may need some sharp dissection by crescent knife. So if you fail to have the big bubble, you have to continue the case as manual DALK. The third group of tips, what we call the tricky situations. We have two tricky situations, what we call the collapsing big bubble and the premature opening of big bubble roof. So watch carefully this example. You see, this is the big bubble. I will show it again in slow motion. Watch carefully. You see, this is a big bubble for sure. You see the edge, and when you go out, it comes out with you. You see the collapse, it collapses. So there is, and when you do paracentesis, you will find the small bubble test negative. So how come there is a bubble and how come it is negative? So this is what I call the collapsed big bubble. Another example, watch carefully. This is a big bubble with a well-defined edge, but when you are going out, it collapses out. Air comes out. You are confused now. How come? And then we're injecting small bubble test. It is negative. But when you inject the air again, the bubble is hidden or collapsed. So the solution for this case is you have to inject a viscoelastic because there is a leakage of air through the tract. So this is what we call the leaking or the collapsing big bubble. Another example, injecting, and when you are going out, watch carefully, the air will come out. And this is the source of leakage. You see this tract is a source of leakage. Okay, why it is crucial to recognize such situation? Because if you have a collapsed big bubble and you don't recognize it, and you go to open the big bubble roof, you will make injury descent membrane because the roof is very close to the floor. I will speak now about the different types of big bubbles according to Professor Dua article, which made a huge difference in our understanding of the mechanics of big bubble. So this is the normal layers of the cornea, and this is what we call the predismatic Dua layer or the Dua layer. So according to this Dua layer, we have three types of big bubbles. Type 1 big bubble with characteristic white edge, and type 2 big bubble with characteristic clear edge, and the mixed type in which we have type 1 and type 2 in the same patient. So this type 1 big bubble, this is a video animation. It usually starts from the center to the periphery, as you see, and it has a maximum diameter of 8.5 millimeter due to the strong attachment of Dua layer to stroma at this side. And as you see, the plane of separation is between the stroma in front and Dua's layer behind. And this is a clinical case. It is characterized by this white edge. This white edge is highly characteristic of big bubble type 1. During the operation, removing the roof, you will be having the floor formed of 3 layers: endothelium, desmet, and Dua's layer, which is very strong layer. Again, this is Dua layer after removing the roof. So this is highly characteristic by its rough surface. Again, type 1 big bubble has characteristic white edge, as you see, and when you remove the stroma, you will be having the floor formed by the tough, rough surface of Dua's layer. Again, another example, white edge, very clear, and the floor is formed by Dua layer, which has a characteristic rough surface, as you see. These are 3 examples of type 1 big bubble with its characteristic white edge. On the other hand, type 2 big bubble is completely different from type 1. It usually starts from the periphery, not the center. As you see now, starts from the periphery of the cornea, not the center. Why? Because there is some fenestrations in dual layer. So when you inject air in the stroma, air will escape from these fenestrations between the dual layer and descent membrane and will form type 2 big bubble, as you see. So again, it usually starts from periphery to the center. It has a large diameter may reach from limbus to limbus. And as you see, the plane of separation is between the dual layer in front and descemet layer behind. That's why we sometimes call it the predesmatic big bubble. This big bubble is characterized by its clear edge. As you see, this clear edge, I will do it again in slow motion. This clear edge is highly characteristic of big bubble type 1 in contrast with the white edge of big bubble type 2. You see this clear edge. What I mean by clear edge. Removing the roof of this bubble will leave only descemet and endothelium. And of course, as you know, descemet membrane is a very smooth, featureless membrane, doesn't have the roughness of dual layer as you see. Another example, you see this clear edge, again by slow motion, this clear edge characteristic of type 2 big bubble, and this after removing the stroma, smooth surface. Another example, the clear edge, very apparent, and after removing the stroma, you will be having a smooth surface. Again, these are 3 examples of big bubble type 2 with its characteristic clear edge. When we go further, the complicated mechanics, we had mixed big bubble. We have 2 types of mixed big bubble. Either complete big bubble type 1 in yellow, and another partial big bubble type 2 in orange. The other example, which is very rare, you have 2 complete bubbles behind each other, complete big bubble type 1 and another complete big bubble type 2. So this is a very complicated mechanics. This shows the mixed big bubble, complete type 1 and partial type 2. As you see, after removing the stroma, you will be having another small big bubble type 2. So this is what we call mixed big bubble. This video, which shows 2 complete big bubbles behind each other, is very unique video and a very rare case. Injecting of air in a stroma, you will be having this edge, big bubble type 1, white edge, and then look carefully, you will be having another clear edge. So see, this is the white edge for type 1, and this is the clear edge of type 2 big bubble. So you have 2 bubbles now. You see? You see? When I do now paracentesis, we will notice expansion of this edge. You see, this edge have been expanded. The type 2 have been expanded. And then we will go for dissection. And now we will do what we call the first brave slash. We will open now the first bubble, you see, but still there is shiny reflex behind. This means that there is another bubble behind. I have opened big bubble type 1 now by the first brave slash. And then I cut the stroma and I will find there is another bubble behind these undulations of descemet membrane, as you see. So I will make now the second brave slash. You see, something still behind. This is another big bubble type 2. So I will do another brave slash now. As you will see, you will find now this bubble. You will see now I will make a second brave slash, which will open the big bubble type 2. So as if you are looking through a textbook of corneal anatomy. This is the opening in dual layer, and this is the descemet membrane, and this is the dual layer. If you compare type 1 with a rough surface, dual layer, but type 2 has a smooth surface. Dual layer is very strong. It can withstand the pressure. This is by mistake, have been hit by a micro sponge. Notice by slow motion how much pressure is applied and still resist rupturing. So this strong behavior of dual layer allows me to do phacoemulsification through dual layer. This is a very unique example of a combined case of keratoconus and cataract. I'm doing first the big bubble type 1, and then making stromal dissection, brave slash, cutting the stroma, and after finishing with the big bubble DALK, I will start do phacoemulsification. Due to the very tough properties of dual layer, it encouraged me to do phacoemulsification through this layer, making the capsular staining, injection of helon, and construction of the wound, and making capsular X's. As you see, phacoemulsification. You can do all the techniques of phacoemulsification through this tiny layer. I'm just remembering you that I'm working through dual layer. So this gives you an idea of how much dual layer is a tough layer. On the other hand, this membrane is very fragile. It ruptures on the slight stroma. So when you are working on big bubble type 2, you have to be very cautious because it ruptures very easily. I will speak now about what we call burst big bubble. Sometimes when you inject air inside the stroma, you have the big bubble and suddenly it ruptures inside the anterior chamber, as you see in this example. Look carefully here. The bubble is formed and then it ruptures inside the anterior chamber. This is what you call the burst big bubble. Another example, the bubble forms and then it suddenly ruptures inside the anterior chamber. Sometimes you may hear a clicking sound of the sound of ruptured descending membrane. This is partial rupture. You see the big bubble is formed and partially ruptured, and there is another bubble in the anterior chamber. Another example of partial burst big bubble. Some of the air escapes in the anterior chamber due to a minute defect in descending membrane. The fifth step is what we call the paracentesis. Of course, after the pressure have been built, we have to do paracentesis. But this paracentesis should be vertical and should be large. As you know, when we are doing phaco, we do horizontal paracentesis. But if you do this, this may damage the bubble from inside. So my advice is you have to do vertical paracentesis to avoid iatrogenic damage of your big bubble. This is the big bubble type 1. You have to go to the furthest part of the cornea in the extreme periphery and make a vertical paracentesis. In type 2 big bubble, as this one with the transparent edge, notice that the bubble expands. So if you are not so peripheral, you will injure the bubble by yourself. Watch carefully this example. This is the bubble. Watch when you open the anterior chamber, this bubble will expand. You see? You see, have expanded. So you have to be very careful. You have to do your opening extreme periphery and in a vertical orientation. This is another example of bubble expansion. This is a big bubble type 2. Look carefully at this site. When you open, the bubble will expand. So you have to be very careful during paracentesis not to damage the big bubble by yourself. The sixth step is the lamellar corneal dissection. This is the easiest step of the operation. You go for debulking of the stroma using a crescent knife. The aim of this step is to debulk the cornea to allow me for the second step, which is roof opening, as you will see now. Sometimes if you have a lot of whitening, to define the recipient cornea from the cutted area, you may make a violet ring. The second tricky situation in this operation is what I call the premature or unintentional opening of big bubble roof. As you know, when we do the big bubble, we do stromal dissection, and then we intentionally open the big bubble roof by what we call the brave slash. Sometimes this opening is done unintentionally or prematurely during lamellar dissection, as you will see now. It may occur at the very beginning of the section. As you see, this is the very beginning, and looks, the bubble have been escaped because I have made perforation of the roof. So this opening of the roof, I call it premature opening or unintentional. Stop, re-inject viscoelastic inside the big bubble space and continue your operation. Or it may occur in the middle of the way. As you look here, in the middle of the way, you see the bubble have been opened unintentionally and air have escaped. So you have to change your policy, go under the stroma and change your policy, and there is no need again for any brave slash. This is already have been done, and continue your operation. The third example, it may occur very late in the dissection. Look carefully to these small bubbles in the periphery of the anterior chamber by the red arrows. You look, they will move now centrally. Look, these bubbles have been moved centrally. This means that the big bubble space have been opened and these small bubbles have moved. So you have to diagnose this situation and you have to manage accordingly. The same principle, you have to diagnose it, because if you don't diagnose it, you may go with your brave slash and destroy a bubble. The fourth group of tips is how to open safely the big bubble roof. So as I have mentioned, this is the roof, a big bubble. I want to open it to get rid of the big bubble space. So the aim of this step is we do a safe opening. We don't want to injure this membrane. And a very important point, this opening should be large enough to allow me to continue the operation. If it is small opening, I will be stuck in this step and will not be able to cut the remaining stone. So this is what I mean by the brave slash. You see, this is a very large opening because you do it very fast and with some braveness. A good tip here to be safe, you put a cohesive viscoelastic over the stroma, and you can do your brave slash. This cohesive viscoelastic will allow air to come very slowly. Another example, look, if you are using cohesive viscoelastic, the big bubble will come out gradually, you see, coming out gradually, so you will be having enough time to withdraw your hand. But what if you are doing a small perforation? Look here, big bubble, type 1, and then you will do stromal dissection, as you see, and then you will do the brave slash, but unfortunately, this is very tiny opening. The air have escaped, but the opening is very tiny. You cannot deal with this tiny opening. You cannot put your scissor to continue the cutting. So you have to stop your operation. You have to make magnification, and you have to spend some time looking for this tiny opening. So that's what I mean, that the brave slash should have to be safe, and you should have a large opening. You will spend some time, up to 20 minutes, looking for this until you find the plane and continue your operation. This is what I mean by large ideal opening. This is a big bubble type 1, and then this is, you see, very large opening. This is the ideal opening that you can introduce your scissor for the next step. Another example of ideal big bubble roof opening, big bubble type 1 again, and then this is a brave slash with ideal size opening that you can introduce your scissors and continue your operation. If you have a minute opening, you will be stuck in this step. So this is a brave slash, as I have mentioned. I always say, don't be afraid. The distance between the roof and floor is large, and if you are hesitant and ended with a small opening, you will be stuck in removing remaining stroma. The 8th step is we continue cutting the remaining stroma. Some advise putting viscoelastic material in the bubble space, but I don't like this step. I prefer using the dry technique, because knowing the dual layer is very tough layer. There is no need to inject viscoelastic, but I go directly by my right and left corner scissors and making the cutting of remaining stroma. As you see, the wound is very neat. This is high magnification showing the wound is very neat. So these other examples of very neat wounds. As I always say, these neat wounds do not differ too much from the amazing femto-laser wounds. It only requires some surgical skills and good quality instruments. The 9th step, the very easy step, is donor stripping. So you have to prepare your stroma, stain the descent membrane epithelium, and try to strip the descent membrane by continuous rubbing by microsponge, and then catching it by McPherson forceps and peeling it. Another example, continuously make rubbing action at certain point until you have descent membrane in front of you, and then peel it continuously. Another example, if you don't have it as a one piece, you can remove it piece by piece. A very important tip at this step is, why not at this step to learn doing the MEC? You are now doing descent stripping. Why not to learn doing the MEC at this step? So you have to use your learning curve in DALK in learning how to make descent membrane grafts. So you are learning to do the MEC grafts in a good circumstances. During your DALK cases, don't forget to practice the MEC preparation. The last step is the graft suturing. This graft suturing is identical to penetrating keratoplasty. No tips or specific for this step, apart from be careful of inadvertent descent. You have to suture carefully, and you have to look carefully to descent membrane during suturing. Otherwise, you may have inadvertent perforation. So whether you do use continuous or interrupt sutures doesn't differ too much. This is surgeon preference. Finally, as you can see, DALK has lots of tricks, but if you follow these steps and advices, I am sure you will be able to execute the perfect big bubble DALK. Once more, I would like to thank Dr. Mazen for giving me the opportunity to be with you tonight. And I'm very happy to have Dr. Bara Kubes with us tonight. And I am ready for any questions. Thank you.
Thank you very much, Dr. Tarek. Amazing lecture, amazing teaching lecture. All tips put together, and a lot of information. Thank you very much. It is a reference, actually. And of course, I'd like to welcome Dr. Nancy Raqad from Amman as well. So let's start the discussion. Dr. Bara.
Thank you, Dr. Tarek, for this wonderful lecture. As Dr. Mazen said, I like the way that you simplified every step. I wrote down a lot of questions, but they were almost all answered during the lecture. So about the small bubble test that you talked about, and the paracentesis that you have to put it vertically, not horizontally. Some surgeons do it before starting even trephination. What do you think about that?
First of all, I want to say hello to Dr. Nancy.
Hello, Dr. Tarek.
Hello, Dr. Nancy. For me, I have tried to make the paracentesis before the injecting air bubble, and some advice doing this. They are doing what we call the double bubble technique. They make a paracentesis and they inject a small bubble in the anterior chamber and watch the behavior of this small bubble during the large big bubble. But I have tried this technique, but actually I don't like it, because when I do paracentesis, I make some softening of the eye, and this softening may let me not very happy during introducing my cannula in the stroma. The mechanics of moving the cannula in the stroma will not be not comfortable to me. So I hope I want to make my my cannula in what I call it the virgin eye. I want the globe to be formed, the full tension, to have the proper mechanics. So I advise not to do the paracentesis before doing the big bubble, but I do it immediately after I do the big bubble, because as I have mentioned, the tension rises very high. So I have to make
release.
Yes.
Also, is there any preferred site to do that? Because sometimes after suturing, you may get leakage from that paracentesis.
Yes, this is a very good question. I usually imagine, for example, the 9 o'clock suture, and just make the paracentesis just above it, because my aim is to be between two sutures. Because if you have the paracentesis in your suture way, if you take the suture before the paracentesis, it will open it. So if you have the paracentesis at the suture line, I have to make the suture very long to include the paracentesis in the suture. So from the start, I try to have my paracentesis between two sutures, and I usually do it just above the 9 o'clock meridian.
Great. After removing the 4 quadrants, how do you let the bed? Do you put some viscoelastic and wash it, or do you just hydrate the cornea?
After removing the stroma?
The 4 quadrants.
Yes, no, there is just washing the stroma for any length material, or just no more than this. I don't use viscoelastic anymore. There is no need for viscoelastic because it has no role. Even some may accuse it of having double anterior chamber. If you do viscoelastic and you don't wash it thoroughly, this may be a cause for double anterior chamber. So just watching by BSS is enough, especially if you are in doubt if some length fibers or something like that.
Okay. Another question regarding manual DALK. Some experienced surgeons say that it's not advisable anymore. So if you leave some stroma, it will affect the vision afterwards. So if you don't have a big bubble, you can just switch to a PKP and go on.
No,
so
no,
what is your experience?
I totally disagree with this opinion. Totally disagree.
Absolutely.
Because we have been proved that leaving less than about 80 micron of stroma gives a very good results as regards the visual acuity. And in my opinion, even if the visual acuity is affected, in my opinion, an 80% visual acuity with DALK permanent results is much better than 6/6 vision, which may be jeopardized by rejection later on. And by doing lamellar dissection by the technique I have mentioned, you can very easily reach a very, very deep plane. I sometimes reach the Dewey's layer without big bubble formation, because when you are making this spreading action by the scissors, you are going every circle in a new plane until you find that the dissection is very easy. This is a clue that you have reached a very deep plane. You will find the scissor is opening very gently. So I totally disagree about this, and you have to do DALK. You try your best, whether by bubble or by manual technique. I think Dr. Nancy agree with this.
Absolutely, 100% I agree with this. Yes.
Dr. Nancy, do you have any comments about the lecture?
Actually, I have a comment. I have to say hats off, Dr. Tarek. I've never enjoyed a talk about DALK like I've enjoyed it tonight.
Thank you.
I was very eager to join. I had the technical difficulty at the beginning, but I don't regret trying my best to just join this seminar. Hats off. I can call you, and Dr. Majid allows, you're the king of Big Bubble, honestly.
Thank you. Thank you.
You've explained every tick and every pearl, every circumstance that we might encounter in the surgical sequence of the procedure, and how to deal with it. And hats off to such a systematic way of explaining it. I cannot say it better than what has been said. And but just one question was that drew my attention. Your technique of practicing phacoemulsification under Dewey's layer. What I do usually is do an anterior lamellar therapeutic keratoplasty, ALTK, which is automated with like a free LASIK flap, and I go like 2/3 of the stroma. I lift the cap off and I do my phaco, and then I put a clearer one. Now you do it, I can see that you're doing the same way, but with a Dewey's layer, with a DALK. What if you did not reach a Dewey's layer? So you do this as a standby? You keep it standby?
The prerequisite for this technique is I should have the big bubble type 1.
Okay.
If I didn't have type 1 and I have type 2, it's impossible to continue as DALK and doing phacoemulsification through type 2 big bubble.
Yes,
so actually, I have tried this technique twice only in my life. And the main aim of this technique was to prove that the
dual layer is good.
dual layer is very strong
enough.
and very stubborn. But actually, it's very difficult to find the combination of keratoconus and cataract.
Yes.
It's not so common combination.
Yes.
But actually, I have tried, and it worked, as you have seen in the video, very well.
Very well done. Excellent. Okay. And
Dr. Tarek,
lamellar surgery is about respecting corneal anatomy. If you respect the layers that you go through, you can just take the cornea to where you want it to be. As Dr. Tarek mentioned, it's not, don't be brave to continue with the big bubble or the DALK to the end, because there's no comparison with the penetrating keratoplasty.
Yes.
So an 80% vision with a DALK is preferable to me than 100% vision with a PKP, to be honest.
Exactly.
So it's about respecting the tissue.
Dr. Tarek, what about the post-op management regarding the medications? How long do you stay on the steroids? When do you remove sutures?
Of course, as regard, I think the main asking about the steroids treatment, we give topical antibiotics for just 10 days. We give lubricants for 1 year. And as regard to steroids, since there is no rejection, we have a very low dose of steroids, but not as low as you may think. I am using for about 3 months. I'm using Optibred or prednisolone 5 times per day for 3 weeks, then 4 times per day for another 3 weeks, gradually tapered for about 3 months. But if I have any steroid response, it's very forgiving to discontinue these steroids and to use fluorometholone. As regards suture removal, for myself, I am one of the surgeons which do not prefer to remove sutures very early, because some surgeons are as if they are making a good job removing sutures very early. No, I'm not that person. I remove suture not before 1 year, and I have a good tip. I am checking the wound scar. If I find a scar, white scar in the wound, even if it is very fine but it's white, I go after 1 year to remove the suture. If I find the scar is very negligible, I may wait for another 3 months or another 6 months.
So there's no difference between removing the sutures in your experience between DALK and PKP?
No, I think no, and I think I am also very keen of keeping the sutures, because in DALK we have the space. If you remove the sutures, you may have some invasion of some capillaries in the space, and you may have vascularization and lipid deposition. So it's very important to keep the sutures, not for PKP only, also for DALK from this point of view.
Absolutely.
So someone of the attendees is asking, for a beginner, what is the suitable cases for him to start?
The suitable cases for the beginner is the straightforward keratoconus cases without any corneal opacities or any scars. These are very, in my opinion, the keratoconus stroma is, as all of us know, is very weak stroma. So they don't have the resistance to resist air. So air can easily make a big bubble. So this is the most suitable cases of keratoconus without any scarring, or if there is some apical opacities, it's okay, but we have to be sure either by the slit lamp or by the OCT that these opacities do not include descent membrane. If these opacities include descent membrane, this means that the membrane is somewhat weak. It may rupture during air injection. So the best cases are the keratoconus cases, either without any opacities or with the apical opacities only.
Great. Any tips for converting to PKP when we have a big bubble rupture?
No, just convert. The question is, any tips not to convert to BKB? So since decided to
I mean, you have
convert,
to make sure that you completely remove the disseminate
Yes.
membrane.
Yes, this is a very important point. Sometimes when you convert to BKB, you cut the remaining stroma, and you think that you did the job, but you find second day that there is another descendant membrane. So I usually very careful about this point, and the tip is I always catch the iris by colibri forceps.
Yes.
If I am able to catch it, this means that there is no layer covering it. But if there is this membrane, I will not be able. So this is a very important point, not to leave this membrane. Try to catch the iris tissue. Being aware of this complication is very enough, because this membrane is glistening and shiny. So if you are aware that you may leave it, it's very easy to recognize that you have removed all of it.
Or we can use the trypan blue to stain the disseminate membrane, any remnant of the disseminate membrane.
Yes,
what do you think?
Yes, a good point also. Good point.
Thank you.
I saw a surgeon trying to rescue some small perforations in the disseminate membrane with a sliding graft. Like he slides the lamellar graft and suture, then he tried to form the eye, then resuture. What do you think about that?
For myself, when I want to rescue my case, I am always the judging in this case is the air injection. I inject air, and if this perforation can keep air inside, so this is for me a good sign that I can continue for DALK. But if I am keeping injecting air and air is escaping, and doesn't form the anterior chamber, this means that the defect is so large, and I may prefer to convert to BKB. And sometimes we use small stromal plugs. If we have moderate size perforation, I may use some part of the stroma to have it as a plug over the perforation. Of course, the problem is if you are doing continuing as DALK with large perforation, you may be having the problem of double anterior chamber.
Yes.
And double anterior chamber, you may have to inject air for too many times. So, as I have mentioned, what's important for me is the stair or perforation is small, and the clue is it maintains air while I'm injecting in the anterior chamber.
Great. I would like to thank you very much, Dr. Tarek. We may spend all the night asking you questions and learning from you, but we have a limit of time. Some people are asking, what is the name of the center if they want to do training with you? And I would like also to mention that you have a YouTube channel that they may benefit from seeing your videos.
Yes. I am honored to have my own workshop in Egypt for about 5 years now, but unfortunately, for some administrative rules in our Ministry of Health, we are not allowed to import corneas for research anymore. So I'm waiting for such rules to be changed and to come back again to make my workshops. But for the time being, if someone is interested, if Dr. Mazen allows me to mention some of the workshops in the near future, I will be having workshop in Saudi Arabia in the Red Sea Ophthalmology Symposium in the 10th of November. And I will be having another workshop in the EPOMEC meeting in Dubai on 15th of December. So these the two DMEC workshops in the near future through these two conferences. And we will be more than happy to invite you as well to Oman, but because of the coincidence of the two conferences this year with the Red Sea, so it's not possible. But next year, please mark your calendar to be with us in Oman. My pleasure, of course. My pleasure, of course. My pleasure, inshallah.
Any last comments, Dr. Nancy?
Actually, Dr. Tarek has been the star of the show tonight. Enjoyed it. I'm very lucky to have joined this meeting. Thank you, Dr. Mazen, for this platform. Dr. Tarek has done tremendously amazing. And thank you, Dr. Bora, for moderating and managing this. So thank you.
Final
I hope
words,
everybody,
Dr.
I
Mazen.
think everybody has, whoever joined this presentation has learned a lot. I myself learned a lot of tips.
Thank you very much.
Any
lovely comments. Appreciate very much these comments, and thank you, Dr. Bara, for this moderation.
Thank you, Dr. Tarek.
And thank you for the big boss, of course, Dr. Mazen, for making it such a wonderful platform to share our expertise with our colleagues. Thank you all.
Thank you very much. I'm not a big boss. I'm a big student. That's it, only.
No, you are. You are.
Thank you very much. Thank you, everybody. I'm very happy today to have such a fruitful discussion. And thanks to all attendees for being with us. I hope to see you in the near future. And Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum. Good night.